Good morning, everyone. My name is Camilo Gonzalez-Velazquez, co-host of the Thyroid by MD's webinar series, and today I'm really honored to introduce a good friend for this morning's lecture on artificial intelligence in thyroidology. Dr. Juan Pablo Brito, he's an endocrinologist and professor of medicine at the Mayo Clinic in Rochester, Minnesota. He currently serves as the Director of Shared Decision Making National Resource Center at Mayo. He also holds the AI and Quality Chair position at the Division of Endocrinology and is principal investigator at the Knowledge and Evaluation Research Unit, the CUR unit at Mayo Clinic. In addition, Dr. Brito contributes as a guideline methodologist for the Endocrine Society as a member of the American Thyroid Association teams for managing hypothyroidism. His extensive research roles include being a principal investigator for two R01 grants from the NIH, one of which includes a prestigious Merit Award from the NCI, and co-investigator for several grants from the AHQR and PCORI. Dr. Brito's research is pivotal in understanding global epidemic of thyroid cancer diagnosis and overtreatment, and the use of levothyroxine in the United States, and the implementation of shared decision makings in the treatment of Graves' disease. He's also forefront for applying artificial intelligence tools to enhance care of patients with thyroid conditions, and with a remarkable number of over 230 peer-reviewed publications, Dr. Brito's contribution to the field have been widely acknowledged. Additionally, in the past few years, he has been awarded in the 2021 as the Early Career Investigator Award from the Endocrine Society, in 2022 with the Van Meter Award from the American Thyroid Association, and in 2023 as Rising Star in Endocrinology Award from the American Association of Clinical Endocrinology. Honestly, he needs no introduction. He's a role model for many of us, and with that notes, I'll leave Dr. Brito to give us his very interesting lecture, and I know we're all excited to listen to it. If I would want to encourage all of our listeners to send in the questions using the Q&A format, and we will try to get as many of them before the end of the hour. So with no further ado, JP, the floor is all yours.
Camilo, thank you very much for having me here. And thank you everyone for attending this presentation. So I will be talking about artificial intelligence and thyroidology, and I will first describe some definitions in artificial intelligence. Then I will move to some of the applications of artificial intelligence in thyroidology, focusing mostly in thyroid nodule and thyroid cancer. Is really a field that is changing very, very fast, and there is a lot of groups working on this area, so certainly I was not able to even start describing everything that's going on with issues of thyroid dysfunction and things like that. So I will be only focusing in some of the applications in thyroid nodule and thyroid cancer. And if you don't get to ask questions or you want to reach out, this is my email and my X handle as well here in the bottom. So I don't have any disclosures. So a few definitions of AI. I think people have on purpose make these definitions very difficult, but there is no reason actually to not knowing it, because there are different ways that we can process this information. And AI in very simple terms is the field of science that trying to teach the machines to think like humans, trying to mimic human intelligence. And to do so, it have used different techniques to train to teach these machines. And these techniques are called machine learning, deep learning, natural language processing, and probably you have heard the famous transformer models. So one way to understand this too is imagine that you have a basket of fruits and you want to teach the computer to recognize apples from bananas. A simple task, but very difficult task for a machine. So one way to do that is by start describing the characteristics of the banana. So it's yellow, it's curved, so on, so things like that. So after describing characteristics of banana, you do it for apples, round, red, or green, and you do it several times. And if you were to apply a machine learning model, what they do is they start identifying the features associated with these outcomes, banana versus apple, and eventually will be able to accurately distinguish between both bananas and apples. So that's a very simple task. Machine learning is very good at that distinction. Now, let's see that you are not only interested in bananas versus apple, but you actually want to know what kind of apple this is. Is this a Honeycrisp apple or a sweet kind of apple? It's a more complicated task, and you really need a different architecture for that. Not really the typical association of variables or trends. You need a deep learning structure, and this is where this kind of a technique is very useful. It actually follows or mimics something how the brain works. So the brain works with neurons connecting to each other in a neural networks. This is exactly how these models work. So they tend to help us in very complicated tasks. So it will read the texture of the apple, even visual texture. It will get this it will get the brightness, the shape, very important structures. And after thousands of apples, it will be able to tell you what kind of apple this is. So these are very simple, not simple techniques, but techniques that are used in AI to do that kind of task. Now, the computers actually communicate with numbers. Humans, we don't use numbers when we are communicating. We actually use letters, words, sentences. So in order for the machine to understand a little bit of how we think, it actually needs to understand language, written language, text. And the bridge between text and numbers, that is natural language processing. So what pretty much it does is turns those letters into a number sequence that represents that particular word or sentence, and then process that information. Then sometimes the output could be a number, it could be a word, and you can use in that setting more machine learning and deep learning to analyze the data. But the natural language processing is that bridge. And over the last 6 years, there was a very famous paper here in 2017, and with that, I think pushed the field forward significantly, particularly for natural language processing, when they started using something that is called the transformer model. And the transformer model is just a very efficient way to process data, particularly natural language processing kind of data, in a way that it brings this meaning of the word in the context of the sentence. So let me give you an example how that might work. So imagine that you have in your electronic health record this sentence. John has tremors and weight loss. Her mother is worried that he might have Graves' disease since her sister has it. So if we were to use traditional natural language processing techniques, we can actually recognize that Graves' disease is a thyroid disease. That would be something that natural language processing can do. And weight is a symptom. So a possible output of a traditional natural language processing, it might be that the system recognizes that it's a possible thyroid issue due to the mention of Graves' disease. If we were to apply now more sophisticated transformer models, the system will actually recognize that John is likely a person, that Graves' disease is a medical condition. The sister has Graves' disease, and might be able to create, or at least to synthesize the evidence like this. John might have Graves' disease. John's mother is concerned that he might have Graves' disease, just like her sister. So as you can see here, this is more closely to how a person might be able to get the idea. So really an advance, significant advance in natural language processing. Now, another concept that you probably hear a lot is foundation models. So foundation models is not, and it's really a big model, like a super model. So when you are doing these techniques of machine learning and deep learning, natural language processing, you can develop a trained models to do a specific task. For instance, in natural language processing, you can have a very good model in summarized text, or you can have a very good model in translating text. But a foundation model is actually a model that can perform all of those tasks, and it does it very well. And one of the reasons why they do very well is because they have been trained in a humongous amount of data, internet kind of a level data. So they really understand language very well. And by understanding language very well, they're able to perform very traditional tasks. And it's not only the amount of data that they get trained, it's how they got trained. So these kind of foundation models, particularly when we think about language, we call them large language models. They were trying to predict the next word. And this is how it works. So imagine that when you are feeding this model with a text, after a while you say, okay, I think we have fed you a lot of information now, many books, Wikipedia, things like that. Now let me test if you get it. And they put a sentence that likely the machine has not been exposed before, and they remove a word at the end. And the sentence will say something like this: people have a deep affection for their animal companions, with a special fondness for dogs, and the machine has to fill the gap, has to fill the next word. And the machine will say, okay, based on my knowledge source, and it will put, and imagine thousands of this, but just an example, it will say, is this is flowers? And say, no, I have not seen in my knowledge source that actually flowers feed this. Is companions, dogs and flowers doesn't really fly. Elephants, maybe the knowledge source have seen some people using elephants coming with dogs and affection, things like that. But the machine will identify that if they were to put cats here at the end of the sentence, it will likely get it right. And once the machine is able to put cats here, the people building the model will say, yes, you got it right. And that would be a positive reinforcement. Say, you did it right, keep doing that. And when it fails, well, it will correct the machine. So after thousands, millions of times, the machine will be very, very good at predicting the next word. And not only that, because if you are able to predict the next word, you can predict the next words, and you can predict the next sentence, and you can predict the next paragraph. And by doing so, these actually kind of models are very good at questions and answers, because the answer is no more than predicting the best answer to that particular prompt. So that is how these models became very good at interacting with us. So by now, hopefully, we have already enough knowledge to understand what GPT actually means. So GPT is not only that generative, is because the models, by predicting the next word, are able to create knowledge, not knowledge, content, text. So they are generative. That is what is called generative AI. So Chat GPT is generative, pre-trained, because it has been training a humongous amount of data in the next predicting kind of testing, a transformer, the model that we were talking about that really help us put attention in the right part and contextualize the text. The chat piece of ChatGPT is only the interface by which we access the model, because you can actually use GPT in many other ways that have nothing to do with your phone or with the internet. They can be used to do predictive analytics. They can use it to summarization in a medical record. But the chat piece of GPT, I think, has been the revolution, because was one of the first times that effectively one of the models was interacting with a human in a way that the humans felt that the answers were good enough. Okay, so that's a little bit of the definitions in AI. Why we are talking about AI? At the end, AI is trying to mimic human intelligence. Why we just don't have, why we just actually need it, why we need to something that mimics human intelligence in the field of thyroid nodule and thyroid cancer, for instance. One of the arguments for the use of AI, I think it's a valid argument, is that we are not enough. And with that, I mean that people treating patients with thyroid nodule and thyroid cancer, we are not enough to cover all the needs. And here I'm just talking about endocrinologists, not to say that these are the only individuals treating patients with thyroid nodules and thyroid cancer, but it's just as an example that there are about 8,000 endocrinologists in the United States. And as you can see in the maps here, the majority of population in the United States will not have access, in these empty areas, will not have access to an endocrinologist. And if they were to have access to an endocrinologist, it will be a significant waiting time. And it might not be an endocrinologist that have experience in thyroid nodule and thyroid cancer. So one of the reasons why we're talking about AI is certainly that is access. Not everyone has access to the right expertise. And the other piece I think is also very relevant and gives the opportunity for AI to contribute to the care of patients is that not only the expertise is difficult to access, but when you access experts, they are busy. They're extremely busy. And what is impressive is they are not busy taking care of patients. Sometimes they are busy just taking care of the administrative task. 40% of clinicians' time in the care of patients is actually spent in documentation, in just writing letters and in administrative tasks. So what that means is that overwhelm a group of clinicians, that people don't have access, and the majority of care actually in thyroid nodule, particularly in thyroid nodule and monitoring of thyroid cancer, is delegated to primary care physicians. So in that setting, I think there is room for AI to help us. And one of the areas is improving diagnosis. So we spend, people who treat patients with thyroid nodules and thyroid condition, we spend a lot of time looking at ultrasounds because ultrasounds have a fantastic amount of information about the nodules, whether we can distinguish between cancer and not cancer, and whether we need biopsy or not biopsy. And to do so, we actually use frameworks that classify features of these nodules in a way that we can score them or just understand the patterns and help us, decide together with the patient whether biopsy is needed. So we look at the ultrasound a lot. And there are now systems that do exactly that make the process in a way that either is automated or at least gives you a very good reading of the ultrasound. One of those is KIOS. This is one of the products that have been already approved by the FDA. And how this system works is that you do the ultrasound as you regularly do, and then the images go to a software. In this case, you are looking at a video of the application of this tool, and is marking the presence of a nodule in the right thyroid lobe. This is the transverse view. This is the longitudinal view. As you can see, the nodule looks already a little bit suspicious. Analyze it, and the output of this is that is actually suspicious, and it gives you the why for it. Also marks where the nodule might be located. It continues finding that there are more nodules, so create a region of interest here. Now this is a transverse view, the longitudinal view, also a little bit hypoechoic. This nodule so is indeed marked as suspicious. You can keep marking the nodules are present. This is if something more isoechoic nodule, but still is an area of interest. So again, as you can see, goes through the analysis phase and gives you the output of that particular nodule. In this case, says not suspicious, which is actually similar to what I had probably concluded. Then presents a report, and in the report, it will look something like this. The output of the model, it will say where it is, the features, where it is, the volume, dimensions, and something that I think is interesting is you can actually see how the machine appraised the features in a way that when it was assessing composition, the higher score was for solid or almost completely solid, but you can see that the machine was actually picking up signals on mixed cystic solid and things like that. And why I think it's relevant is because you can actually override this. This can be just an initial reading of the system, and you can certainly override it in a way that says, no, I disagree. And as you can see already, this is not a system that should go alone. These are systems that are supposed to be used together with the radiologist or whoever is reading this in a way to support the reading, but not to replace the reading. Now, where I think this might be useful, and the way that these systems are advertised, is that they might be useful as to shorten the time of reading. So in fact, there is some evidence that it saves about 22, 25% of the time that takes to read things. What I find it helpful in a way is that gives some consistency in how things are read. So we humans are very good at not being consistent. So the inter-rated agreement, meaning if I were to read something and I ask a colleague to read something, the same nodule, well, it's very likely that we read it differently. So this brings some consistency in the ways that we read. So I think that would be a plus. Now, when you think about these models, even if they are FDA approved, it doesn't mean that you should use it. And I would like to encourage you every time that you see any of these products to go back to the literature behind these systems, because the majority of the times are small studies, or the majority of the nodules are used, but the nodules that they are using are the ones that you can actually read them very well. So they are very good in quality. They are not really problems with the pixels of the picture. So they are chosen in a way that the machine can read them well, and that's not really something that's in practice we face. We face all kind of pictures, all kind of ultrasound. So I think they lack some general issues of applicability to every setting. Now, another tool that has been in the market, I'm not quite sure if this is FDA actually, is a tool that will give you a 3D picture of a nodule. So this is how it works. The sonographer or radiologist or endocrinologist, it will go in the typical machine that they are using. They will have to put this piece of a sensor here that is activated wireless, and then it should perform a regular scanning of the neck. In this case, I think it's mostly in the left, or I will see what actually in the right. So performs a regular scanning that I think it takes more time than the one shown here, but anyway, it goes to the system, processes the information, and then you have those pictures here in the software. This is the transverse view of the left thyroid lobe. This is the sagittal view, and then you can see actually the coronal view. Here in a minute, you will see the tomographic view, the 3D view in a second. So then it can get the volume of the left part and say, you know what, this part actually is not the left, it's the isthmus. So, but it will cut it and it will say the volume is about 8.8 milliliters of volume. And then we'll start scanning and say, oh, there is something here in the close to the isthmus that looks like a nodule. Well, let me mark it an area of interest and say, you know, let's accept it as a possible nodule. And after the machine accepts, and you can see marks in the three views, it gives again the features of that particular nodule in terms of composition, echogenicity, and so forth, and provide a thyroid score here in level 3, and you can actually accept it or discard it or just modify that. So you can accept it, it says the volume, the largest diameter, and then you can build the 3D model of the nodule. Here is showing the left thyroid lobe, and here showing the nodule close to the isthmus. So where I think this might be useful is in the procedure part of things. So if you were to entertain radiofrequency ablation or ethanol ablation, or even to discuss potential active surveillance in nodules that might be located in the posterior part or next to the vessels or anteriorly, this might provide a little bit of that 3D structure for you to understand what things might be before the procedure or in the monitoring of the nodule. In fact, they tend to show this image here of a very large nodule that's going to go for radiofrequency ablation, and this will be used as a baseline for follow-up of the nodule after the procedure. So things like that are already available for people to use. Now, the main limitation I see with something like that is that you really actually have to pay for things like this. And again, it might be fed systems with nodules that are really high quality. The ultrasound probably is high quality. But if you were to practice in a rural setting, or let's see, outside United States in a rural setting, who you might not have that quality ultrasound, and the radiologist is a radiologist that is not specialized in thyroid cancer, so you feel like you need to have a second opinion and you don't have an endocrinologist, a colleague that you can ask. What about really understanding whether chat GPT can help us? And the reason why that might be a source of help is that ChatGPT now has what is called computer vision, meaning that can process images. And for instance, in this case, if we were to say this nodule, as you can see, the quality of the ultrasound is actually not good, but you are able to see here there is a nodule. In fact, it looks a little bit suspicious, hypoechoic. And if you were to ask GPT in the right way, so you prompt the machine to say, this is how I want the output of my question. Please tell me what is the thyroid score for this particular nodule. You have to show that this is the nodule. The output of ChatGPT is actually something like this. This is the actual output of the question. So presents the composition, echogenicity, shape, explains what they are. Then they give you the points, which it seems like a very reasonable reading of this. And then it presents what the guidelines says in terms of recommendations for biopsy and not biopsy. And of course, it highlights that this is an assessment that you have to see it with caution because it's just one piece of information. So should we use ChatGPT for something like that? Not yet. In fact, everything that we do with machines, it has to be tested in a research environment. And in fact, many of us, a group, is trying to assess the accuracy of ChatGPT, particularly in answering this question. So we are coming up with a series of ultrasound pictures, and we are testing the machine, comparing with two radiologists to see the extent they have similar results. So anyway, it's still the potential that might be useful if proven accurate. Now, but something in the field of AI is still truly understood, but and amazes me every time I read about it, is that we humans see things in the images the machines don't, or that the machines go beyond that. What I meant is for instance, examples like this. This is a retinal picture, and we use it, endocrinologists and ophthalmologists, we use it all the time to understand whether there is presence of, for instance, of diabetic retinopathy. And there are many other applications, many other things that you can get from the diagnosis, but they are very typical, and we know what we can get and we know what we cannot get by looking at this. So models, AI models, looking at these pictures are able to go beyond what humans can see. So they can actually detect diabetes control. They can tell you whether you have poorly controlled or high control, or where the 1C might be. They can predict heart calcium scores. Kidney disease, looking at the retina, they can predict kidney disease. And what amazed me the most is that a couple of studies actually show that by looking at retinal pictures with specific AI models, you can predict Alzheimer's disease and Parkinson's disease years even before you start developing the symptoms. Of course, these are really in the early stage of the development of the applications, but they hold promise that maybe this might be as a marker of future Alzheimer and Parkinson. And that makes me think that, well, what else is hidden here in the ultrasound pictures that can help us in the future? And likely future studies might uncover many important things that we're missing. So maybe the ultrasound will serve us as a way to see whether the nodule is going to grow. We actually have no way to predict whether the nodule grows or not. There is already work ongoing in predicting or identifying mutations. What if we can predict whether the patient is going to develop hypothyroidism, or even the biological age? So there is the chronological age and the biological age. And the biological age, which means how old are actually people inside them, is a predictor of many other things, including perhaps Alzheimer's disease and Parkinson's disease. So I wouldn't be surprised if future studies shows that there are markers within the thyroid that can predict other non-thyroidal conditions. Similar work or interesting work also happening in FNA and pathology. So these are now digitized in a way that groups can run AI algorithms in these pictures. And now we know that there is robust work in predicting Bethesda categories. Now just looking at the FNA slides, you can identify BRAF and RAS with looking at these pictures. And I think the future might be in the prediction and prognosis. So to what extent we can identify whether this is going to be an aggressive papillary thyroid cancer from a non-aggressive beyond what the typical traditional pathologic factors that we use. So it's going to be, for instance, that intermediate risk PTC that sometimes behaves as a low risk and might be able to differentiate from the ones that behave as a high risk. Prognosis, it means that maybe we're able to predict whether the patient is going to respond to radioactive iodine or TKIs and things like that. In fact, there is exciting work happening in how can you see the immune cell architecture within these pictures, and by predicting the shape of these immune cells within this tissue, maybe you can predict response to immunotherapy. Or detecting collagen fiber within these pictures might actually predict aggressiveness. So there's a lot of work going on in different markers that were not really even considered as an important by us humans. Okay, how can we actually use AI in practice? And this is hopefully a more practical part of the presentations. So something that is coming is the AI scribes. And this is already happening in different healthcare systems. Maybe your healthcare system already implementing this. And the principle is that if you were to record the conversation between patients and clinicians, either through a phone, microphone, or any other device, the machine might be able to transcribe this conversation through a system. It's going to summarize it in a way that you don't need to, at that moment, start typing. And by freeing you from typing, you can actually pay attention to the patient. So it holds promise in the sense that will free you from those documentation tasks and maybe even prescription tasks or the laboratory request lab. So it's supposed to help clinicians in those tasks as well. The caution here is that it's not like the note will be extremely accurate. In fact, I'm still very surprised that while many of the AI scraps company already been implemented, the evidence behind their usability and transparency and content accuracy is still limited. But nevertheless, they're still being now implemented in practice. So it's not the kind of text that you just leave it alone and you consider well done. You actually have to go back to the note and read it to make sure everything was correct. So whether that is actually trade-off of documented versus reading after, I think that's something to discuss. Now, let's see though, and this is something that you can certainly do it now, that you are seeing a patient that has, unfortunately, a very fast-growing metastatic medullary thyroid cancer. And you're thinking that a patient will require selpercatinib. And you say, you know what, please draw me a very detailed assessment and plan of a patient like this. So this is an actual output of one of those models. And without any additional instructions other than what you're seeing here, it provides already a very good draft that you might or might not want to edit and use it in your note. So it goes into treatment strategy, medications, monitoring, management, side effects, and so on. I say, okay, this is good. You might want to edit it, or you might want to change things. But you know what? I would like the same thing, but something that my patient will understand. Take away the jargon, make it in a way that my patient will be able to take home and read it without any help, and can do that very well. So this is the output. Getting the right medicine describes why you are getting this, how to take it, who might be checking on you, the side effects, and things like that. So these are outputs of current models that are available pretty much to anyone right now. This, in fact, is an output of oximetry, which is an app that many people have. It's a medical app that if you were to use this information, you will get these similar answers. Now, let's imagine that patient tells you, I'm concerned about cost, there is any resource for me to entertain or at least to consider to lower the cost of these very expensive medications. So you can type, help me with resources for these particular medications and with links or references that the patient can access. So this is an actual output. It tells you, this is a website that you were to click here. It will take you to this website, and it's a saving card system. So likely the insurance company is providing this, and that might be something for patients to consider. Another one is this link that I was not aware that actually put all the charities organizations that help patients with cancer and financial problems. So the potential to help patients with resources, because it connects the question with even things that I have not really been aware, is fantastic. So think about community support, social support, that otherwise you will have to type in Google and trying to make sense of everything. This is summarized in a way that it will be in seconds at the point of care. So I think this would be a very useful use of these models in care. Now, after you prescribe the medication, you actually get the typical annoying portal message that says, by the way, the insurance actually deny it. And the nurse says, do you want to write a letter? And I think you think the patient needs it, and of course you want to appeal to it. So you can actually type, I want you to write a letter for me to support this, the medical necessity and clinical appropriateness of the treatment. And I want you to provide that and the citations that by which the FDA approved this medication. So this is a short part of that draft, because it's actually, you can put your name as a doctor, and it gives you exactly on behalf of and the information that you might have for your institution, and describes the medical necessity, the studies behind it. As you can see, is actually citing correctly, libretto, the study that actually was used to approve this medication, the clinical appropriateness and urgency of treatment. And if you want, you can just, of course, fill the gaps of here, patient information, and then send it to one of these insurers. As you can see, we are not, and you should not use patient important information in any of the models ever, because this is not information that stays in your computer. This is information that leaves your computer. So if you were to use the models like this, never use real information or patient important information. Now, what about the use of these models in portal messages? So this is an area that I think we were really hoping for AI to help us. So there are very interesting studies going in this area as well. So one of those studies is that they test humans to the extent whether they can differentiate whether the results of a question placed in the portal is a machine answer or is a human answer. So people that were not exposed to this before. So it's kind of the Turing test for this. And we humans, we barely distinguish the answer. So 65 thought that was correctly AI and 65 humans. So really, really almost like a flipping a coin. We barely were able to identify whether a response was from humans or a response was for machines. And when they were asked, would you trust the answer if this answered by my machine? And the majority of people doing this exercise say, no, I will not trust the answer of a machine unless it's a very low risk health question. So that tells you something, no? It's the output of that might be very similar, but people still have low trust. So another interesting study now assessing the response from the physician compared to the response from the chatbot in questions about care in a public social media forum. And as you can see here in hundreds of questions, the majority of people that were not aware whether it was a machine or a human actually preferred the machine responses. And you can see the distribution here, response options, very good. The chatbot responses are more likely to be good and very good. The physicians were most likely to be acceptable. And here in the empathy rating, the physicians were in the non-empathetic kind of answers. The chatbots were very empathetic. And these were not actual questions in the portal that were public social media forum questions. So I think we have to see it like this. It might be that the way that we respond to patients in the portal is different than the way that we respond people in, for instance, in, I'm not sure, in X or Twitter or Facebook. Now that took us to the famous KOKO experiment that I think is fascinating. So this is KOKO was a company that had an app that connected people that require mental health support with people who can provide that support, peers, not necessarily experts, but there were people that we wanted to have some interaction. So people that have depression, anxiety, and they really need to talk to somebody or to interact with somebody. So the app connected both. At one point, the company told the people that were responding to these messages that they can use AI to respond to the messages. And the users were not aware of this. At the time that this happened, the users can actually rate the responses as good or bad. And when they transition from human only to AI responses, the response time decreased by 50%. So the responses were much faster. And the users rated higher the responses by machine than the humans. What is extremely interesting about this study, not this study, this thing that happened, because I don't think we call it experiment, is that when humans realized that the responses were coming from the machine, they actually stopped using the software, despite having better responses than sometimes the humans. Now, there is significant issues of ethical problems here. In fact, this group never got even an IRB approval to do this. But I think highlights a very interesting thing about human nature. We don't like fake responses, and which is very relevant for future use of AI. Okay, so I move forward now with research. I do think that AI, if something has a lot of potential in research, one area that I think will help us a lot is registries. We in the United States, we don't have good registries for thyroid cancer. The one that we use the most is the SEER data set. And this is a registry that's nationwide, and is a very manual, resource intensive process to get these registries. People had actually manually to extract this information and put it in the SEER data set. Somebody has to curate it, has to confirm it. And this resource intensive process means that not every state here in the United States is contributed to this data set. And not only that, is that we actually don't have good registries in regards to the treatment that patients are getting, how the patient responds to treatment, what are the symptoms of the patient's response to treatment, the granularity to the pathology of these patients. And because we don't have this kind of good registries, we rely on single center experience. If you think about the risk classification, stratification studies, mostly based on very few institutions, which limits actually the applicability of that in different diverse settings. So our group is working in this area. We are actively developing the virtual registry AI system. And this is based on the principle that we take care of patients, we thyroidologists, we endocrinologists, we thyrosurgeons, we produce a significant amount of information that we were not collecting. Every time that we do an ultrasound, we have the report, very rich report, the biopsy, also a lot of useful information. Pathology has probably the most useful information for predictive purposes, but the follow-up, how the patients are feeling, whether there is fatigue, whether the patient sees the cancer coming back, we certainly are not capturing right now. So we are developing a system right now to capture this information and develop automate extraction and developing a registry from there. So imagine that, for instance, this patient, we can tell why the ultrasound was ordered. We can tell what was the result of the ultrasound. We can tell what kind of a test that was it, whether we can tell whether molecular test was used, what is the output of the molecular test, the features of the cancer, and what happens with the patient later on. So as proof of principle, for instance, this is results of how we are doing this work in extracting information for thyroid ultrasound reports. So we annotate these ultrasounds in regards to the features of the nodule, size of the nodule. This is work already completed by the group led by Dr. Sino Spina and Dr. Youngwei Gu in the University of Florida. And these are the results of the model. As you can see, all the features and very good performance. Anything above 0.8 is good enough. And for thyroid score, very good performance, for instance, quality, size, risk description category. So very promising results in way to extract this information. Similarly, we are wrapping up a project of pathology, extracting information for pathology, again, with very good results. What is the future? I do think that eventually this text information along with imaging will be very useful to also support the practice. Imagine that we do a multimodal, meaning all the models, text, imaging together, and we can use to do some predictions, summarizations, and questions answering. Think about example like this. Now in practice, taking the research to practice, you can actually interrogate the pathology report or of the data that you have for the patient. Let's see that you are a primary care doctor or you are a nurse practitioner and that you have to see this patient because the endocrinologist was not aware, or that you are an endocrinologist who is mostly focused on diabetes and you need help. So you can say, for instance, could you please review patient's information and tell me what the risk of thyroid cancer recurring is? And say, based on everything that the patient has is 20 to 30% in 10 years, and the recurrence is more likely to be in the central neck or the left neck. So, that's helpful. We can actually monitor or we can focus on that areas that we'll consider more likely than areas in the right neck, for instance. So what treatment is recommended to lower this risk of recurrence? Well, you can actually do thyroid hormone suppression, and that might decrease it by 15 to 25%. And you can say, why not radioactive iodine? And the model can actually answer the tumor seems to be BRAF-like tumor. The chances to respond would be less than 5%. Based on the pathology, based on the images, the models will be able to tell you if something is more BRAF-like or RAS-like kind of tumor. And I think this kind of AI research might help us answer big questions in thyroid. So the overdiagnosis, we're finding the small thyroid cancers and they are not changing the mortality. We can understand where these tumors are coming from actually now. This is a mapping of where the tumors come from a small sample at Mayo Clinic. As you can see, the majority are coming from imaging. Many are not indicated or inappropriately done. And we are trying to see whether this is actually something that we can identify at scale. So many institutions understanding how frequent this inappropriate in ultrasound is, because if we know how often it happens, we can actually intervene and decreasing the overdiagnosis of thyroid cancer. We just published a model right now that's able to do exactly that. It tells you based on EHR information whether or not the ultrasound was done inappropriately, not to punish the clinician, is not the intent, is to actually understand what are the factors associated with inappropriate use so we can intervene at the level of avoiding future use and also maps the reasons why the ultrasound was used. And I think many other uses in scholarly activities, I think this is very easy to use now for writing papers, reading papers. And I think this is a very good use of AI right now because you are always overseeing this process. And I think, Camilo, I see that we are 7:50. I will skip the education part of things, and I will just go to my final be aware kind of conclusions is this is a map of applications of AI in thyroidology. This is how the field is changing. We did this systematic review. It was led by Dr. Toro Toban that shows that in the field of thyroid cancer and thyroid nodule, we're expanding these applications significantly. So you can see here how compared to 2018, now we're many studies going in thyroid nodule, thyroid cancer. But what you need to be aware is that the majority of these things actually stayed in training and validation. And in order for us to consider that useful, you really need to have utility testing, which means that likely a clinical trial that shows that it's useful in practice. And hopefully many of those, we go through the process of having FDA approval to do this. But as you can see here in this systematic review, we found that there is a leaking of this. So many studies start this, and only few actually get approval by the FDA, or at least pass the utility testing part. So it's very limited what has been regulated, and very limited what is actually clinically tested to be used. Now, be aware, many issues with AI, many issues. One of those is that depending on the model, it can make up things. It's called falsification. So it means that the output of the model, you have to read it carefully, because it can make up references or it can make up things. Is biased because the data that we feed the machines is also biased. So it perpetuates the bias. So if we only have thyroid cancer data of majority of patients that might be male or woman or specific ethnicity, it's likely that will not perform very well in a different diverse group. We do not know very well how those systems work. So for instance, if we were to ask one of these systems that predicts the nodule, or predicts, for instance, Alzheimer, how actually detects Alzheimer 7 years before, we do not know. So there is a black box in understanding. And in healthcare, we really want to at least know what kind of part of the models is driving this. There are issues of privacy, regulation, as well as the very important issues of misinformation. How can you misuse AI to create misinformation? So with that, passing it back to you, Camilo. I'm happy to take any questions. Thank you.
JP, thank you so much for this very interesting and thought-provoking lecture that you're giving us. I really hope that we had like an hour to speak about each and every one of your slides, because there's a lot of food for thought there. I'm gonna go right to the questions from the audience. Dr. Jonathan Wasserman and Dr. Hua Chen have sent in questions, and they both focus on the legal aspect and how we protect information from patients to when applying artificial intelligence analyses in data from for example from EHR from electronic charts. So this could go on forever, but what is your two sentence
Yeah,
from how do we
the
protect
privacy and regulation of this is extremely important. And there are some efforts right now to trying to limit the extent to which these companies have access to data that patients have not consented. But it might be too late. It might be too little too late. And the reason is that the majority of work happening in AI doesn't happen in the traditional, well-structured environment of an IRB, of a hospital. Maybe we can control things. What's happening right now is that institutions are actually wrapping the data of patients. They identify that, so at least that happens. But they are either selling or letting some companies use the data. But if you think about it, we have not really consented to it. So there is a significant bioethical problem right now going on, is to what extent we should be aware when our information is shared and used to develop such models. The counter argument to it is that if we were to just super regulate these processes, we will not have the innovation on AI. So I do think that there are ways to move it, continue with innovation, yet respecting patients' privacy. You know, HIPAA, for instance, you think about the historic perspective of HIPAA, was exactly when we were starting developing the electronic medical records. There were a lot of concerns that my information is not going to be secure in the basement of this building anymore. It's going to be aware for anybody. So HIPAA came to protect us from that, privacy, security, and still help us in innovation. So I think there is still room to get something like that that regulates AI development, but also make sure that our data is secured and not leak or not shared without really us agreeing to. But there's still a lot of work in progress in that area.
Thank you so much, JP, for that. Dr. Urken, do you have any questions?
Yeah, terrific lecture and extremely timely, and very thoughtful. And we're privileged to have in the audience one of the developments of IBM Watson. And if you recall, Watson was held out as hope that it would be kind of that that voice on the clinician's shoulder who was in the room and providing guidance to the clinician. And very much of what you are describing is very kind of Watson-esque in terms of its role, but very expanded. Watson didn't work out the way it was originally designed. How do you have a sense on what the hurdles were for Watson to play that role, and how AI will be significantly different?
Yeah, I don't think I have a good answer for why Watson did not pan out. So maybe it was too early. Maybe the timing where Watson was trying to have a role in healthcare system, the healthcare system probably was not at the right time. So I think the revolutions in AI, the one in which it moved to deep learning. So that was the first big revolution. One of the revolutions, the performance of these models were actually not that good until deep learning came. And deep learning said, you can do vision, and these are fantastic outputs of this. So that was a significant change in 2011, 12, 13. The performance of these models changed. That's around Watson, I think, was also trying to intervene in healthcare. And then the transformer models in 2017 that pushed the particularly large language models to be very efficient. What I personally think where things are changing is how people now perceive this, because these models were already to some extent implemented in some practices, but the ChatGPT, the Google models that people can actually play with really open the imagination of how this can be used in healthcare. So my answer is maybe the timing was not there, because I don't think it was a technical problem. I think the timing might not be there. How we collected the data was not there. Certainly, that's another piece. Computing power might also have not been there for all the institutions doing this kind of projects. So computing power is humongous what you need to do. So certain variables might not have been at the right time for Watson, but I do understand that IBM continues to have some presence in healthcare with, I'm not sure it's Watson or something similar, but I will not say perhaps that Watson is dead. But I will, I know who you're talking to, so he is the right person to see if there is any future Watson.
Okay. Yeah, just one other question here. What are you personally using at this point? Obviously in an experimental setting, but what's happening in your clinical practice that and what can you say about that?
Yeah, so I use ChatGPT. So ChatGPT has two versions: the free version, that is a 3.5 version that is available for anyone to use, and the 4.0 version that you pay $20 per month. And the reason why I use the 4.0 version is that we're actually doing this study of the ultrasound with us. So we really need the computer vision of ChatGPT, and that is the paid version. But the 3.5 actually does very well. And I use it mostly for scholarly activities, meaning I'm reading a paper and I say, you know what, can you please summarize the evidence for this particular topic over the last 2 years? And ta-ta-ta-ta. Or I'm drafting something and say, it doesn't flow very well. Can you please fix the flow and grammar, make it more elegant? And the audience is this, and gives me a very nice, well-developed draft. But as you can see, I use ChatGPT as an assistant of the work that I am doing, and also use it with confidence because I know the output. If I were to be using an output I cannot understand, let's see that I'm in charge to write a paper for breast cancer that I have no knowledge. The output for ChatGPT, I will not be able to make sure that it's right, which is a paradox here. Because in order to use these tools, you actually need to know whether the output is good enough. So if you are not an expert of the field, I will caution that you really need to go deep into this text and make sure it's accurate, because it makes mistakes. So I use it mostly for refinement of text, summarization task. I use it also to brainstorm ideas. Actually, that's a very cool thing. You can start talking with these models and say, this is an idea. Can you refine my pitch for this proposal? and helps you do that. And there are many other uses, but if you were to use any of these things, make sure that you know what you're getting and make sure that you are the right person that knows that the content is right. Because otherwise you might make mistakes. Never take it for granted. Their systems are not yet there.
Great.
JP, I have a quick question just to follow up from
Yeah.
that. You were mentioning when these models do not know the answer, they predict what the answer should be, which people who use this call it a hallucination from the model. They make up things based on what they know. So you showed us that retinal picture, and that was beautiful. And it can predict, for example, gender or diabetic retinopathy. That's awesome. But then you ask yourself, but how? You know, like, how did that happen? You called that the black box model. How do we open the box? How do we solve like the biological link between what's happening, what the model is predicting? That's one question. And how do we make it not be biased by the ivory tower kind of data that we're feeding it? Because most academic big institutions are using it. However, it's being taught the information from those academic centers and not necessarily from the rural areas that you were mentioning. That data might not necessarily apply to any given user.
No, that's a very good question. This black box issue is a very important issue in AI and applications in healthcare. And this is the problem. So there is a balance here. One thing is that the model can perform very well and might not be able to tell you why, because all the connections that are made might not be a way for us to see exactly what happened. There are some efforts to do some mapping of where things were. So what is the machine reading that is telling you about Alzheimer? It might be some efforts in that area. But in order to improve the interpretation of the model will sacrifice performance. So in order to know exactly what happens, the model will not be able to perform that well. And this is another paradox. Will clinicians accept a model that performs better or a model that tells you why it's performing and perhaps the accuracy drops? So that is the balance right now. Some people actually say, I don't really care as long as it has been tested, the output has been tested and predicts with accuracy. I don't really care what is going on inside. Other people say, no, I really want to understand what is the algorithm that is being used, what variable is actually driving this. There are some AI techniques that people are being developing to trying to come out with an answer. What I have read is that it's very unlikely that interpretability will come up without suffering, without performance drops. So that is an interesting question that will happen in the field. So we will sacrifice performance for interpretability versus, just keeping as is. And the question about data, yes, you're right. So the data is extremely important. If you were to feed the machine with specific amount of data, will reflect the limitations of that data. And there is lack of rurality, the lack of diversity in many of the data that we have. There are vast number of examples how these algorithms are biased towards women, are biased towards minorities, because the majority of healthcare data doesn't actually represent women in many conditions. Research, the majority don't represent women in many conditions, and the same with more vulnerable groups. So the algorithms might perpetuate bias, and is very problematic. Very typical example, one that surprised me always, if you were to ask, where in the past, you put an algorithm that says, for instance, this person actually robbed the bank and run away from the police. Can you tell me the ethnicity? So the people actually were tricking the system, and the system was racist. So just to tell you that this is, again, we have to be extremely careful with these kind of models, because they are perpetuating bias that the society has or might have.
Great. Camilo, I think we have to call this. I think this has opened the door for a follow-up session for perhaps a roundtable discussion. I have one last question and to close. And again, thank you, JP. Was any of this lecture prepared by AI?
The pieces of assisted practice, but yeah, some of those outputs were clear outputs of the model. So other than that, no, I did it myself.
Okay, awesome. Thank you so much. Have a great
Thank you for the
holiday.
invitation. Thank you, Camilo and Mark, and thank you, everyone. Take care.
Take care. Be well.